Hmm. Come, Chaitra sir. आज पे क्या करूँ?
Start, sir. You are live.
Okay, good evening, everybody. Welcome, all of you. I have a small announcement to make today. Before we go on to the second grand
Start,
round
sir.
from
You are
Vijayawada. So the announcements which I have to make today are, today we are going to have a grand rounds from Vijayawada by Professor PSN. Okay, good evening, everybody. Welcome. So as you know, I'm going to again introduce him because yesterday some of you might not have seen, but I'm very happy with the response which we have yesterday, because I saw on the Facebook 3,000 people have seen it right on the Facebook alone. So that makes a total of around 15,000 people who have seen the whole program yesterday. So Dr. PSN Murthy sir has graduated from Kurnool Medical College, and he did his MS from Jipma Medical College, and he started working in Manipal Medical College, and then moved over to Vijayawada in 2001. And he served as the HOD of the Department of ENT in Pinamani Siddharth Medical College, and then now is the principal of this college. He's dedicated his life, the whole life, to serve the students of ENT, and the fraternity of ENT is really proud to have him as our mentor teacher. And so we decided to have our mentor as Professor PSN Murthy Garu, and he is actually from Vijayawada, which is a state which is in the southeastern part of India. And for those of you, yesterday I saw several people who have seen it from Bangladesh, from Pakistan, from also from Mexico, and so many other countries. So we're going to have Dr. Samira, who is a final year postgraduate, and today's topic is Cholesteatoma. Before we start this, I've got a few announcements to make. The first announcement is the second grand rounds from Alembic. So this is being mastered and mentored by Alembic along with Royal Pearl Hospital, and we're going to do it on February 19th and 20th by Professor Ravi Nair sir. He's the ex-HOD of St. John's Medical College, and he's currently the Dean of the Center of Academics and Research, HCG Hospitals, Bangalore. So stay tuned on 19th and 20th of February, 8 p.m. And we have one more announcement to make tomorrow, in case any of you are willing to come to Visakhapatnam. We are there for doing the skull-based workshop. It will be a very fantastic event with a lot of very nice cases like craniopharyngiomas and cellular meningioma and things like that. So if you want to join us in Visakhapatnam, you're most welcome. So without much ado, we will start with the presentation by Dr. Samira. Yesterday, she did very well with a CA larynx. And those of you who have not seen it, it's still there on my Facebook page. So today we are going to do a case of Cholesteatoma. And here we are, over to Dr. PSN Murthy sir.
Yeah, thank you, Janki.
Thank you, sir.
So we'll proceed with the a year case presentation. The basic idea is how the case is going to be presented, how the case is, how the history is being taken, how the clinical examination is being done, and then how do you correlate these two things and come to a logical conclusion and plan for a treatment policy. That's what we are looking for when you are examining for the long case for about 45 minutes. You have the time for examination. So this is what is expected from any student, is good history taking, a complete clinical examination, then come to a logical conclusion, a diagnosis. If you cannot come to a diagnosis, a differential diagnosis, and then finally plan for a treatment. This is what is we are going to discuss in steps. Right, Dr. Samira, are you ready?
Yes.
Yeah.
Good evening. A 27-year-old male patient named Praveen
Dr.
Kumar.
Samira, please hold the mic close to you. Number one. Number two is please be slow, because yesterday there was a little bit of poor understanding by some of the people around the world. They have written to me that Dr. Samira is very fluent but very fast. So please.
Yes. A 27-year-old male patient named Praveen Kumar, resident of Vijayawada, came with a chief complaint of left-sided ear discharge since childhood and decreased hearing of the left ear since 5 years. History of presenting illness. The patient had complaints of left-sided ear discharge since 12 years, which was continuous, scanty, non-blood-stained, foul-smelling discharge with no aggravating and relieving factors. There is a history of decreased hearing of the left ear since 5 years, which was gradually worsening. Initially, it was for the whispering sounds, but at present, the patient is unable to hear normal speech. There is no history of ear pain in and around the ear, no history of ringing sensation, no history of reeling sensation, no history of fever, headache, vomitings, no history of any usage of ototoxic drugs, no history of symptoms suggestive of facial nerve weakness. There is a history of recurrent nasal complaints with nasal discharge and nasal obstruction, and there are no throat complaints.
Yeah. At this point of time, we get back to the first complaint. His main first chief complaint is a left-sided ear discharge
Yes.
since childhood.
Yes.
That means the 27-year-old old patient, is having ear discharge or autoria of 12 years
12 years.
duration. That means obviously that the discharge started somewhere at the age of 13 to 14 years. 13 to 14 years. Is it a significant factor? Okay, right. Now you said the patient has a left-sided ear discharge, and what are the characteristics of the discharge? Autoria?
It is a continuous discharge, scanty in quantity. It is not blood stained, and it has a foul smelling character to it, and there are no aggravating and relieving factors.
Is it the foul smelling according to the patient, or
According to the patient.
according to the he complains of foul
foul-smelling
smelling,
discharge.
foul smelling ear discharge. Okay, right. Continuous ear discharge, scanty, non-blood stained, foul smelling discharge with no aggravating or relieving factors. Are you pointing out to a diagnosis, or
It comes out to be a squamosal type of chronic discharging ear, sir.
it usually all these usually this sort of a discharge is usually seen in a squamosal
Squamosal
disease.
type of-
A squamosal disease or a attico-antral type of disease. Right. We'll take each one as a say. What are the causes of ear discharge? A very simple basic question. What are the common causes of ear discharge?
Otitis externa.
Starting from the external ear,
Otitis externa, sir. Then ASOM.
acute
Acute
suppurative
suppurative
otitis
otitis
media, right?
Chronic
Then
suppurative otitis.
chronic
media,
suppurative otitis media,
tympanic or reticoantral type.
reticoantral type of disease,
Uh,
and then
CSF otoria, sir.
CSF autoria,
Tubercular otitis.
tuberculous otitis media. When will you get a profuse ear discharge?
Acute exacerbation of chronic suppurative otitis media.
Profuse. Where will you have a profuse ear discharge?
ASOM also. ASOM discharge.
ASM will not contain that much of a ear discharge.
Mucosal type of tuberculosis.
Means the mucosal type of ear discharge, mucosal type of disease. If you are having lot of discharge coming out even after cleaning, What do you call that sign?
Reservoir.
Reservoir sign. Where will you see a reservoir sign?
When there is a mastoid reservoir.
Usually when the
mastoiditis.
mastoid cellular system is involved, usually you will have a lot of plenty of discharge.
Yes.
Because the surface area of the mastoid and mastoid cellular system is more.
Yes.
That's the reason you'll have more air discharge. Right. Now you also said it's a foul smelling discharge.
Yes.
What are the causes of foul smelling air discharge?
One could be a secondary bacterial infection, so by anaerobic organisms, and two, it could be due to underlying bony osteitis, which could cause
Underlying
foul
bony
smelling.
osteitis. So both the things
Bony
can cause a
destruction.
foul smelling air discharge, a bony destruction or a secondary contamination, secondary bacterial contamination, probably
anaerobic
anaerobic organisms. That's what you are mainly concerned with. Now again we'll get back to the blood-stained air discharge. When will you get a blood-stained air discharge?
When there is a granulation
From the external ear onwards into the middle ear. Trauma. The most
to the
important cause of blood-stained discharge is
a trauma to the
trauma. Then
granulations.
granulations in the external canal.
In case of an
In which conditions you see
blood-stained-
granulations in the external canal?
squamosal type.
In the external auditory canal. Granulations in the external auditory canal.
Malignant otitis externa.
Malignant otitis externa is number one. Another thing. Where is in malignant otitis externa? Do we call it as malignant otitis externa now?
No, so skull base
We don't call it as malignant otitis externa. We call it as a skull base osteomyelitis at present. Now, when any other condition where you can have granulations in the ear,
Squamous cell carcinoma.
you can have malignancy of the ear also is very important. External aortic canal itself can cause blood-stained discharge. So you have to be very careful about the external aortic canal. Any other conditions where you can have granulations in the external aortic canal, where the canal is widened?
Keratosis.
Keratosis. You have a condition called as keratosis obturans, where the drainage of the external aortic canal is hampered. This hampering of the drainage of the external aortic canal is because of these granulations. Though the canal is so wide, even then that there is no drainage of the canal. So that's the reason why you have a granulations which can cause again a blood stain discharge. Also, why are you so much worried about the aggravating factors and relieving factors?
If it is a mucosal type of disease, any upper respiratory tract infection will aggravate and cause a ear discharge. Sorry, if it is a tubotympanic type of disease.
Especially in tubotympanic diseases. Especially in tubotympanic disease, you can have both the aggravating factors by any upper respiratory tract infection can cause a
acute discharge.
Acute exacerbation, or it can increase the secretion. So you are that is one of the biggest differentiating points between the tubotympanic disease and a aticoental disease. That is mainly that's what a mucosal disease or a squamosal disease. Okay. So this patient is having since last 12 years, almost since last, since he has become an adolescent, because this is a point very important for us when you are coming for the treatment point of view. This point is going to be very important because since last 12 years, since he has become an adolescent, he is having this particular problem of scanty blood stain, foul smelling, ear discharge. Right. It is continuous.
Yes.
Right. Okay. Now, what is your second complaint?
Decreased hearing in the left ear since 5 years.
Decreased hearing. So since the beginning, he didn't have the
No, sir. He
hearing
appreciated
loss.
since 5 years.
He appreciated that change in decrease in the hearing since last 5 years. Okay. What is what is the characteristic point of this particular hearing loss or decreased hearing?
The patient initially, 5 years back, when he first noticed, he was not able to hear any whispering sounds. Sir. It was gradually worsening, and at present he can't even hear the normal conversation speech also.
Okay, that's what his complaint
Yes,
is.
sir.
He
Complaint.
himself complains that he is not able to hear on the left side.
Yes, on the left.
Okay, right. Right. Anything else? Any other significant factor in this hearing? So what are you, this much of a hearing loss at this point of time, at this point of history taking, history, what does it suggest to you?
Since he's having a
Are you-
continuous ear discharge since 12 years, sir, I would like to consider a chronic type of disease of the middle ear, a chronic otitis media. Since the discharge is scanty and foul smelling, and there are no aggravating and relieving factors, and it is not.
No, we are talking about the hearing.
Yes, sir.
He is not able to hear the whispering sounds. He is not able to, now he is not able to hear the normal speech.
Yes, sir.
Will it give you, is this information giving you any clue to your diagnosis?
Yes, sir. It is a progressive hearing loss. Where
It's
there
a
is
progressive hearing loss.
and more of a conductive type, sir.
How do you know it's a conductive hearing
One, if
loss?
the patient, we'll ask about if he can comprehend to the speech or not, sir. If there is
Yeah.
loss of comprehension, it is a sensory neural type. If the comprehension is normal and only the hearing is affected, it is a
Absolutely.
conductive
Absolutely.
type.
That's that usually the question what you are going to ask the patient is, are you able to hear the sound and understand it, or are you not able to hear the sound and not understand it? Speech reception also is important. So when the speech reception is affected, that is usually occurs in a sensory neural hearing loss. So in a way, we also can, to certain extent, can differentiate towards a type of hearing loss in the history itself.
Yes.
So this is, so you have a patient who has got a ear discharge, who has got a patient here who has got a hearing loss, probably a conductive hearing loss. Conductive hearing loss. He's not able to hear the normal speech. So what does it mean? Can we comprehend that the quantity of hearing loss?
Yes, sir. Normal speech usually is in the range of 50 to 60 decibels, sir. So if the patient is not able to hear the normal conversation, I would consider a hearing loss of about 60 decibels.
60 decibels obviously means the disruption is.
Almost ossicular involvement.
You also expect an ossicular involvement in this case because he is not able to understand the normal speech, which is not usually not a common case. Right. So at this point of time, we have got a ear discharge. Patient has got a ear discharge, which points out to a chronic suppurative otitis media squamosal type. And then we have the same patient has got a conductive hearing loss, probably a hearing loss more than 60 decibels, a moderate conductive hearing loss. Probably he may be having an ossicular discontinuity also. So almost from the history itself, we can almost come to certain conclusion about the diagnosis and type of the disease. Now you have mentioned so many complaints below. I mean, what do you exactly want to know by all these symptoms? You wrote about ringing sensation, reeling sensation, fever, headache.
I would like to rule out the complications associated with the CSOM.
For every year case you do this, or in this particular case, in this case you would like to have more information about these particular
In this
conditions.
case, it is of interest because it is I'm considering it to be a itochondral type of CSOM.
Okay,
And long-standing disease.
A long-standing itochondral type of chronic suppurative otitis media is likely to have
More complications.
complications. So what are these complications? What do you call these complications?
Intracranial or intratemporal
No, basically they are all arising from the ear.
Yes.
So it's an autogenic complication. Autogenic complications can be, there are several complications which can come in that. So the symptoms related to these complications you are taken into consideration and trying to rule out each complication. Is it right?
Yes.
So, okay, let's take first thing we have to put it as a pain in the ear.
Yes.
When will you have pain in the ear when the patient is having a medullary discharge? What are the conditions
If there is an
where
associated otitis externa,
associated arteritis externa,
then presence of a mastoiditis.
arteritis externa, right? He has an arteritis externa. How is he going to get arteritis externa?
Because he is having a continuous discharge, he will be probing his ear and trying to clean the ear, sir.
Yeah, number one,
Repeated
traumatic.
meddling,
Probably it is a traumatic arteritis externa because of the itching. Because the patient will be having a lot of itching in the ear because of the ear discharge. So the patient will have a
otitis
arteritis externa. The second cause for the arteritis externa is
water entry.
your discharge coming into the ear.
Continuous discharge.
The discharge itself can cause a secondary arteritis externa. It need not be the infection from the exterior. See, the external artery canal can get infected only through two sources. If there is a perforation, through the middle ear. If there is no perforation, it is only one source.
Nasopharynx or
External artery canal. External artery canal can be infected only by the exterior, from the exterior. If there is a medullary disease,
with the perforation,
the discharge continuously coming into the external artery canal, you will have you can have an external arteritis, right? So here, that's the reason why you are asking for the pain, right? Number one. Any other causes of pain in a case of medullary disease discharge?
mastoiditis.
Mastoiditis, right? Number one is an arteritis externa. Number two is
Acute acute
you can have a
coalescent mastoiditis. Acute mastoiditis presents with pain.
acute mastoiditis usually will present pain. When will you have pain in this case? When there is a discharge or when there is no discharge?
When there is no discharge.
When there is no discharge, when there is a discharge is getting collected in the either in the mastoid cellular system or in the middle ear, getting that, in that case you will get the pain. As long as it is discharging into the external artery canal, there may not be any pain at all. So these are the common causes of pain in a patient who has got a middle ear disease. You also next you mentioned about the
history of ringing sensation.
Ringing sensation. Better term?
Tinnitus.
Tinnitus. We don't call ringing sensation, we call it as tinnitus, right? When do you expect tinnitus in a patient with a middle ear disease? The patient has a tinnitus, what does it signify?
If there is an inner ear involvement,
Can conductive hearing loss cause tinnitus? Yes or no? Will you get tinnitus in atherosclerosis? It's a conductive hearing loss only, no? Then, can you get tinnitus in conductive hearing loss? Yes, you can get tinnitus in a conductive hearing loss, but very usually you get tinnitus in inner ear. This is cochlear, mainly when the cochlea is involved. So, if the patient is having a chronic a middle ear disease discharge with the tinnitus, it is not 100% that it is inner ear is involved. There is a possibility of inner ear involvement is definitely to be considered, right? Next again we'll go back to the reeling sensation. Exactly what do you mean by reeling sensation?
Patients have symptoms of dizziness or vertigo, sir.
Giddiness or vertigo, right? If the patient with the middle ear disease has got vertigo, so what does it mean?
Involvement of the labyrinth.
It 100% it is labyrinthine involvement. Only?
No, sir.
Then what are all the what are all the problems you suspect when the patient complains of vertigo?
If there is a third window formation and through the perforation there is a air hitting onto the third window, it can cause if the semicircular canal is
Yeah,
activated
number
to
one,
that, it could cause
involvement of the inner ear, either by the disease going into the inner ear, or this is affecting the inner ear. Again, any other condition you suspect,
cerebellar.
you also suspect
Cerebellar
it can be a cerebellar problem. It can be a cerebellar space occupying lesion, usually in a cerebellar abscess. Again, so it is not only the inner ear, it's also the cerebellum also you need to consider into this thing. Right. So if the patient has got no reeling sensation or no vertigo, it doesn't still mean that inner ear is not involved. It only means labyrinthine involvement, not the cochlear involvement. See, he can have a cochlear involvement without any reeling sensation, without any vertigo. So that's what. Right. Okay. Let's go down towards your fever, headache, and vomitings. What are you planning to rule out?
I would like to rule out some intracranial complications like meningitis.
Okay. Now that you mentioned about the intracranial complications, what are the intracranial complications? You know,
Meningitis.
meningitis,
Intradural abscess.
subdural abscess.
Intra autogenic brain abscess.
Oh, yeah.
Otitic hydrocephalus, lateral
Otitic hydrocephalus, lateral venous, lateral
sinus thrombosis.
the sinus thrombosis or thrombophlebitis. Lateral sinus thrombophlebitis. Otitic hydrocephalus. Right. In all these conditions, you get this fever, headache, and vomiting.
No, sir.
If the patient has got fever, headache, and vomiting, what sort of, these are all the conditions you are going to consider. Can you differentiate between them?
Severe
And
fever,
if suppose the patient has got a continuous fever and headache and vomiting, what type of projectile vomiting? What is your diagnosis going to be?
meningitis.
Meningitis or it's a sign of meningeal irritation. Meningeal irritation. So the patient will be having a continuous fever, headache, continuous headache, and projectile vomiting usually indicates a meningitis or meningeal irritation. The patient's fever is not continuous,
If there is a spiky picket fence
spiky
type of
picket fence type of fever, you will get in.
I would like to consider lateral sinus thrombosis.
You will like to consider lateral sinus thrombophlebitis. That means the picket fence fever means the temperature goes up and again comes downward down,
And
then he'll have a window completely free of normal. No, he won't.
It does not reach the base.
It does not reach the baseline. That's how you differentiate lateral sinus thrombophlebitis from what is the other condition which causes a same sort of spiky fever? Malaria. That's how you rule it out from malaria. Malaria also causes a spiky fever. But in malaria, the temperature comes down to the base level. The patient remains feverless for some time and then again shoots up another spike. So that's how you rule out a malaria from a lateral sinus thrombophlebitis. So the patient is having fever, but not continuous fever, low grade fever, and headache and vomiting. So what do you suspect now?
Brain abscess in case of
You expect a space occupying lesion. That means a brain abscess. So what are the types of brain abscesses which you see in middle disease, in autogenic complications, intracranial complications? What are the types of abscesses you see?
extradural abscess.
That's not brain abscess. There are all several types of abscesses. One is at the level of the dura and the membranes. The other one is the content of the brain. So there are two different types of complications you are getting here. One is the cover, one is the content. Cover, content. In the cover, you have extradural abscess, subdural abscess you have. Then content,
brain abscess.
brain, you can have a brain abscess in the, when you have brain abscess, which lobe is affected?
Temporal lobe
It is a temporal lobe abscess. The other one is
cerebellar
a cerebellar abscess. So, because how does the disease go into the brain from the middle ear?
through the preformed pathways, sir. Either natural dehiscences
Yeah.
or
By
retrograde thrombophlebitis
or by venous thrombophlebitis, or most commonly through preformed pathways because of the destruction. Because something has already destroyed and made a pathway, the infection immediately goes into the this one, through the pathway. Right. Now, the abscesses, you mentioned about two types of abscess. Right. One is temporal lobe abscess, the other one is cerebellar abscess. Are these abscesses occur very close to the ear? Are they very closely attached to the temporal bone?
temporal lobe abscess, yes, sir.
So-
Cerebellar abscess,
The infection spreads contiguously. It's not a distant abscess. The abscesses are in relation to the temporal bone. In relation to the temporal bone. That's very, very important. Because nowadays we don't do this, but earlier days we used to drain the cerebellar abscess or even the temporal lobe abscess from the mastoid. Transmastoid drainages we used to do earlier days. So they are all contiguous. The disease is spreading by continuity, not by a distant infection. Okay. The patient, usually the fever, what type of fever usually you get in a brain abscess? A low grade fever or even subnormal temperature. Temperatures are below the base level. Below the base level. Right. Uh, you also then now you mentioned about the autotoxic drugs. Why? Why do
if the
you
patient has
do you mean to say the autotoxic drugs systemically, or do you mean to say autotoxic drugs tropically? Tropically. Do you mean to say that is contributing to his deafness?
Yes, sir. I want to rule out ototoxicity as a cause for the hearing loss.
When you already found a cause,
Yes, sir.
you know that there is a midline disease. You also know that there is the disease, all the symptoms are pointing towards a squamosal type of disease. Then will you consider autotoxic drugs? No, you should consider topical autotoxic drugs
For the discharge
contributing to the increase since last 5 years. See, here is a patient for 12 years he has got the disease. But for 7 years he didn't have any hearing problem. After that only he has got the hearing problem. So possibility of the tropical ear drops contributing to the
hearing loss.
increasing in the hearing loss also need to be considered. Right. Okay. Go ahead. Next.
There is no history of symptoms suggestive of facial nerve weakness. There are
Why are you worried about facial nerve?
Since it is a middle ear disorder and facial nerve, the horizontal portion of the facial nerve, and we are considering etiquetal type of disease, which can cause erosion of the bone.
Yes, you are considering facial nerve because facial nerve is the content of temporal bone and the middle ear. It is the content of the middle ear. So, in any middle ear disease, it can be affected. So that's the reason why you are looking for a facial nerve weakness level. When you come to the examination, we'll talk about classification and staging. Right.
The patient has history of recurrent nasal complaints of nasal discharge and nasal obstruction, sir, since childhood.
Significant? Not significant.
Significant.
Very significant.
Yes.
But whenever you have a patient with who has got a long-standing from the childhood, he has got nasal discharge, nasal obstruction. Will you expect only a unilateral ear disease?
No, sir. Bilateral ear disease.
Usually you expect a bilateral ear disease. But here the patient has got no symptoms on
He
the,
does not give any history of symptoms of the right ear.
he has got no symptoms of the right ear. He is not complaining anything about the right ear. But is it possible that he have to have some symptoms, some signs indicating on the on the right ear too?
Yes, sir. Since it is a, I would consider nasal pathology, it would usually involve both the ears.
Both the ears. So you also expect, though they
Some
may not be
findings,
symptomatic.
Yes.
Though it is not symptomatic, still there can be some signs, telltale signs of a ear disease on the other side also. Though he has no complaints about it. Right, we'll proceed. No throat complaints, absolutely no problems. Yes. Okay. Right.
Past history, the patient has no history of hypertension, diabetes mellitus, tuberculosis, asthma, epilepsy, or jaundice.
A 27-year-old man, you expect him to have all these problems.
Tuberculosis.
Tuberculosis, probably yes. Tuberculosis, yes.
Asthma.
Asthma, probably yes.
Epilepsy.
Yes, if the patient says he had epileptic attacks. So what will it ring a bell for you?
An intracranial brain abscess.
Again, you'll seriously consider having something wrong with the intracranial complications. No, having said intracranial, kept on we are talking about intracranial complications. That means obviously there are some extracranial complications.
Yes, sir.
What are these extracranial complications?
Extracranial are.
They are all outside the brain or
intertemporal.
inside that?
Extracranial are again of two types, sir. Intratemporal and extratemporal.
Extratemporal, right. What are the intratemporal
Intratemporal complications are facial nerve paralysis,
facial nerve, involvement of the facial nerve, right?
labyrinthitis,
Labyrinthitis, right?
petrositis, sir.
Petrositis, yes. Extratemporal,
Extratemporal Bezold's abscess, City's abscess, Lux abscess.
any of these abscesses outside the temporal bone. Outside the temporal bone coming into the head and neck. Coming into the head and neck. So there are different types of abscesses and each abscess is named after somebody. So you have several abscesses. But anyway, those are not as immediately related to the condition what we are discussing. So you should know what is Bezold's abscess. Where do you see Bezold's abscess?
The sternocleidomastoid, a collection of abscess beneath the sternocleidomastoid.
Usually, how does it occur?
Trickling of the abscess collection through the sternocleidomastoid muscle and then collection in the neck.
Sternocleidomastoid is attached to?
Mastoid tips.
Tip of the mastoid. So anything from the tip of the mastoid coming under below the sternomastoid muscle. Right, okay. City's?
Involving the digastric muscle and collection in the submandibular regions.
Coming almost towards the digastric into the digastric triangle. Right.
The zygomatic abscess.
Zygomatic abscess.
In case of a well-pneumatized mastoid extending to the zygoma, if the air cells are extending to the zygoma, it can form a zygomatic abscess near the zygoma.
Okay. So there are several abscesses in the leg. Can Bezold's abscess or digastric abscess, can they become a parapharyngeal abscess?
Yes, sir,
Yes.
they can.
They can also become a parapharyngeal abscess because these spaces are interrelated in the neck
region.
upper part of the neck. These are all the spaces which are all interrelated and interconnected spaces. So you can also have a parapharyngeal abscess. So these are the abscesses outside the head and neck. Okay, fine. Right.
Coming to the personal history, he takes mixed diet, bowel and bladder habits are regular, sleep and appetite are normal. Coming to general examination.
No, we'll stop here. Now, At this point of time, with all the history you have taken quite a detailed history. With this history, summarize your positive points in the history, and then we'll see whether we can come to a diagnosis.
So the patient has a history of left-sided ear discharge since 12 years, which is continuous, scanty, foul-smelling, and non-blood stained, and with no aggravating and relieving factors. And he also has a left-sided decreased hearing, sir, since 5 years, which was gradually worsening, where initially he appreciated only for the whispering sounds, and now he can't even hear normal conversation sounds. And the patient also has also gets history of recurrent complaints of recurrent nasal complaints since childhood. So these are all the positive history.
These are the positive, and you have written so many negative history.
Yes, sir. There are no symptoms suggestive
Of any
complications.
complication, either extracranial or intracranial complications. There are no signs, no symptoms suggestive of any complication. So, what could be the possible diagnosis at this point of time?
An uncomplicated type of squamosal type of chronic suppurative otitis media.
Chronic suppurative otitis media, squamosal type,
without any complications. And with moderate conductive hearing loss.
At this point of time, this is going to be your working diagnosis. Will you consider tuberculous otitis media in this case?
No, so tubercular otitis media.
What are the usual characteristic features of a tuberculous otitis media?
Painless otorrhea.
Painless otorrhea. You have the painless otorrhea here also.
Presence of a facial nerve palsy.
Facial nerve palsy can be there or may not be there.
Yes.
You have painless otorrhea here.
Yes, but since 12 years, it is a chronical.
Tuberculosis also is a chronic.
No fever, sir.
He has no symptoms suggestive of
tubercular.
Primary tuberculosis. Primary usually the autogenic tuberculosis. The tuberculosis of the middle ear is usually secondary to pulmonary tuberculosis. So here you are not having any symptoms of pulmonary tuberculosis. So at this point of with this working diagnosis, we will see what your examination reveals.
Coming to the general examination, the patient is conscious, coherent, and cooperative. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. Vitals, blood pressure is 110 by 80 mm of mercury, pulse rate 84 beats per minute, and temperature is FF5.
Right, you have a robust young man here. You have a robust young man without any comorbid conditions. That's what you are looking for. Right. Is an ideal case for surgery.
Yes, sir.
Right? Okay. Now.
Coming to the local examination, the preauricular area, there are no scars.
Which ear are you talking about?
Sir, first I will talk about the left ear, sir. And
the affected ear, the ear with the complaint.
Yes.
Right.
Preauricular area, there are no scars, sinuses, swellings, or skin tags. The pinna.
If you have a skin tag, what do you call that? No, you can sometimes you have a skin tags in front of the.
In front of the ear, sir.
What do you call that?
Tags, preauricular tags.
What? Okay, go ahead.
Pinna appears to be normal in size and shape.
No, you also mentioned about sinuses and swellings.
Yes,
What are you looking for? When will you get a sinus or a swelling in the preauricular area?
Preauricular sinus.
Preauricular sinus. Anything else? When will you get a swelling?
Is there parotid lymph nodes or lymph nodes in the preauricular region?
Preauricular
lymph
nodes. Okay, you can have preauricular lymph nodes. You can have a
preauricular sinus.
cyst. You can have a preauricular cyst, which gets infected and becomes a preauricular abscess, and then becomes a preauricular sinus. Do you know what is a collateral fistula?
Yes, sir. First branchial cleft fistula is called coronal fistula, sir. It is of two types. One which is external and lateral to the facial nerve, and type 2 is where it is going deep to the facial nerves, extending into the external artery canals.
The second opening is into the external
External artery
artery,
canal.
into the external artery canal. Right. Okay. There are no scars, no sinuses, swellings. The preauricular area is absolutely normal. Okay, fine.
And coming to the examination of the pinna, it is normal in size and shape. The postauricular area, there are no scars, no swellings, no edema, and the postauricular groove is normal. Examination of the
When
external
will you have an obliterated postauricular groove?
in case of furunculosis,
You can have a furunculosis of which wall?
posterior wall.
Posterior wall. Furunculosis of the posterior wall of the external artery
External
canal. Usually you'll have a
obliteration
obliteration of the postauricular groove. And another condition?
thickening of the periosteum.
Periosteal thickening
of
again. Usually secondary to when will you get periosteal thickening?
Mastoiditis,
With chronic mastoiditis can cause periosteal thickening. These are the conditions where you are non-tender postauricular groove obliteration. Right.
External artery canal. On the left side, there is scanty foul-smelling discharge present within the floor of the bony external artery canal, and the skin of the external artery canal appears to be macerated.
Appears to be macerated. Is it a significant finding?
Yes, sir.
Okay.
Since the patient has a chronic history of ear discharge,
Okay.
which is continuous, then the skin could get softened due to the continuous discharge. And also because he keeps cleaning his ear.
Okay. The macerated skin is secondary to the chronic
middle ear disease.
chronic middle ear discharge. Right. Now you said the discharge, the scanty discharge is in the floor of the bony external artery canal. Usually, which point, in which place this discharge gets collected? Anterior recess. The anterior recess. And do you know the boundaries of the anterior recess? The anterior recess is formed by the
A shallow
tympanic membrane on one side and
tympanic membrane medially and
why do you have anterior recess? Why don't you have posterior recess?
the temporal.
What is the angulation at which the tympanic membrane is situated?
45 degrees of
55 degrees angulation. So because of that angulation, you have the
there is anterior recess formation.
area in the anterior place which is deeper than the posterior. That means the posterior part of the external artery canal is closer to you.
Lateral,
Is closer to you, and anterior part is away from you. Right. Okay. So there is some amount of discharge collected there. Thick discharge. What type of discharge is this?
purulent.
Purulent. Frankly, purulent discharge, mucoid discharge, or mucopurulent discharge. We didn't talk about the type of discharge. What are the types of various discharges you know?
Serous discharge
Serous. Where do you get serous discharge?
in early otitis externa.
Otitis externa. Usually in the skin. From the skin you get the serous discharge. Right.
Then
Mucoid discharge from the
middle ear.
middle ear. Which part of the middle ear?
Anterior portion of the middle
Anterior
ear.
part of the middle ear where the
Goblet cells.
goblet cells are present. Goblet cells are present. That means purely a mesotympanic disease. Mesotympanic disease. So by the type of discharge also we will be able to come to a diagnosis. Suppose you get a mucopurulent discharge.
Mucoid component along with the secondary bacterial
Secondary, it can
infection.
be secondarily bacterially contaminated. Frank purulent discharge.
In furunculosis.
In furunculosis, you can have frankly purulent discharge. And
Then if there is a secondary bacterial infection of the Cholesteatoma collected debris.
again, you have a frankly purulent discharge. Okay, right. There's, at this point of time, there's no blood stain discharge.
No, sir, there is
No, okay, fine. Right. Why don't you complete the left ear and then come back to the right ear?
This is the tympanic membrane.
Okay. Okay. The left tympanic membrane, right. Okay. Now describe the left tympanic membrane.
The pars flaccida, there is.
Before going into the examination, tell me what usually when you examine the tympanic membrane, what are the points you take into consideration? In a systematic way,
Yes, sir.
how do you examine the tympanic membrane?
The intactness of the tympanic membrane, the color of the tympanic membrane,
You are talking about which part of the tympanic membrane?
pars tensor.
So then you examine two parts,
Yes,
pars tensa and pars flaccida. In the pars tensa, what are the things you are going to look for?
Tympanic membrane, color of
Color of the tympanic membrane,
texture of the tympanic
texture of the tympanic membrane,
the landmarks of the tympanic membrane,
landmarks are
then, the handle of the malleus.
they are the landmarks. Okay, fine.
Then the glistening nature
Glistening.
of
The tympanic membrane normally glistens at you.
Yes.
Yes. Position.
Position of the tympanic
Position of the tympanic membrane. Whether the tympanic membrane is gone inwards or
touch.
pushed outwards.
Yes.
So in which condition it is pushed outwards?
In case of acute separative
Acute
aortic
separative arteritis media, which stage?
stage of separation.
Stage of separation. Usually, stage of pre-separation itself, it starts bulging,
Yes.
but it heightens towards the stage of separation. Okay. Position. Then, finally, pathology.
Yes.
Is there, what is the pathology seen there? No, these are the things you have to consider in an order.
Yes.
This is about pars tensa. About pars flaccida, what are the things you look for? What is the, where exactly is the area of pars flaccida?
Subtoprusax,
No, clinically, when you are looking into the tympanic membrane, we are doing an otoscopy
above the level of the malleolar.
about the level of the both anterior and posterior malleolar folds. So what are the area, what are the pathologies you are looking for here? What is the tympanic membrane here? Is it the same? Is it the same as Schaubner's membrane? Is it the same as the pars tensa?
No, sir, not.
No, it's not same as the pars tensa. So it is more
prone for retractions.
it is more transparent. Why?
Fibrous layer is
The fibrous layer is absent in the Schaubner's membrane, so it is more transparent than the pars tensa. So you look at the again color of the tympanic membrane, then position of the tympanic membrane. So
if any erosions of the sputum, I would like to consider.
that is pathology. First thing is intact membrane. Then comes destroyed membrane. Right? Okay. So we'll leave the left, right here. Let's go back to the left here. So first describe the pars tensa of the left ear.
Pars tensa, the tympanic membrane appears to be thickened.
Tympanic
with loss
membrane
of,
doesn't look
glistening
normal.
surface.
Pars tensa, the tympanic membrane doesn't look normal.
It has a thickened appearance, sir.
The tympanic membrane
Usually
is
has to be translucent.
thickened.
In this case,
It's not. It's not translucent. You're not seeing any structure
Yes, sir.
through the tympanic membrane. Through the tympanic membrane. Right.
Then the loss, the normal glistening surface of the tympanic membrane is lost, sir. Then the cone of light is distorted.
Can you see the cone of light?
No, sir, it is not.
You are not seeing the cone of light. No, you are actually seeing the cone of light. At the extreme corner, you can see a small piece of. It's a distorted cone of light, no, not absent cone of light.
Distorted
Right.
cone of.
Distorted cone of light. Okay.
Then there is congestion in the posterior portion of the tympanic membrane, sir.
Posterior
Posterior
superiorly, you are having congestion, and even in the midline. Even in the midline also, there is congestion of the tympanic membrane. What is more, which is looking at you on the posterior aspect of the tympanic membrane?
Reddish granulation.
You are seeing reddish mass there, but medial to the Tympanic
Tympanic
membrane.
membrane.
So it's still covered by the tympanic membrane. It's not frank granulations presenting out. Probably there are granulations behind the tympanic membrane. More than that, you see the, what is that whitish material you are seeing there?
Square epithelium,
You are seeing a lot of whitish material.
desquamated epithelium, which is cholesteatoma.
You are seeing cholesteatoma almost coming down. The same cholesteatoma which is above is almost coming down into the posterior superior quadrant also. Right. Okay. Then that's about pars tensa. Now, what landmark which you expect in that midline?
Handle of the malleus.
You are looking at the handle of malleus. Can you see the handle of malleus? No,
No, sir.
you are not able to see any structure in the tympanic membrane in the pars tensa. Right. Okay. I get it. Then go to the pars attic.
Yes, sir. There is erosion of there is a pars tensa perforation with erosion of the outer attic wall. Sorry, pars flacida, erosion of the outer attic wall, and there is a discharge collection.
Why do you say there is an erosion of the outer attic wall? Actually, you are seeing a bony. You are seeing a part of the bony segment on the anterior aspect there. On the anterior aspect, you are seeing a bony segment protruding into the attic. Number one, and number two,
the fundus?
The depth.
Depth
The
of the
depth
pars
is so
flacida.
much.
Yes.
and you are seeing the whole of the attic.
Attic region.
Whole of the attic region, whole of the epitympanum you are seeing actually. Normally now you don't see the entire epitympanum. You only see a part of the epitympanum. The rest of the epitympanum is covered by the scutum. And only when the scutum is eroded, then only you will see the entire epitympanum. Now you are seeing the entire epitympanum. You are also seeing a bony spicule there. And then what are the other things you are seeing? What are the things you are supposed to see and not seeing there?
Head of the malleus.
You are supposed to see the head of the malleus, but that it doesn't seem to be clearly visible there. Then
The body of the incus.
you have a swelling in the posterior epitympanum, which is covered with
Cholesteatoma.
which is covered with cholesteatoma, right? And that area also is
In
no, the same congestion is going upwards into the epitympanum also. Right. Now you summarize all the findings of the left ear.
pars tensa, the tympanic membrane appears to be thickened with loss of listening surface, and there is distortion of the cone of light, and there is a congestion in the posterior superior region with probable granulation tissue, and there is a cholesteatoma collection in the posterior superior quad beneath the tympanic membrane. I can see a whitish appearing cholesteatoma collection, and the normal landmarks like the handle of malleus could not be visualized.
Yeah, true. But posterior to the supposed place of head of malleus, you are seeing a gap there.
Yes, sir.
You are seeing a gap protruding. I mean, almost like it's caving into the posterior epitympanum. So probably what you are seeing may be the cholesteatoma around the body of the probably there may be body of the incus may be there in that area. That's right. So here you have a patient who has got both the findings in the pars tensa and also in the pars flacida. There is an attic perforation. The perforation is more in the anterior attic, and there is a destruction of the scutum, and posteriorly there is a bulge in the posterior epitympanum which is covered with cholesteatoma, and also there is reddish like either a congestion or some granulations in the right side. That's about the attic. So here is the patient who has got basically a perforation in the pars
Pars
flaccida with some findings in the pars tensa. All right, okay. Can you comment on the, now that we have different modalities of ear surgeries, will you comment on the ear canal, external aortic canal?
Anterior portion is not clearly visualized.
No, the width of the or the diameter of the external aortic canal, because suppose somebody wants to do an endoscopic procedure, is adequate. The external aortic canal looks adequate. It's quite comfortable. You can even attempt, for attempting an endoscopic surgery also is suitable. Right. Now let's go back to the previous slide and come down to look at the other ear.
Right ear examination. The preauricular area, there are no scars, sinuses, swellings, and skin tags. The pinna appears to be normal in size and shape. The postauricular area, there are no scars, swellings, edema, and postauricular groove appears to be normal. The external artery canal in the right side is normal in size, shape. There are no bony overgrowths, and the skin of the external artery canal appears to be normal.
Right. Patient has got no complaints in this ear.
No, sir, no
Yes.
complaints in the right.
But now again describe the pars tensa first, then describe the
Pars.
pars flaccida.
The pars tensa, there is a grade 1 retraction of the tympanic membrane with which is tympanic membrane appears to be dull.
The tympanic membrane appears to be dull, right?
With distorted cone of light. Then retracted.
Where the cone of light? Okay.
Then retracted tympanic membrane with the prominent lateral process of the malleus and anterior and posterior malleus.
Okay.
Pars flaccida.
Anything else in the tympanic membrane? Anything in the pars tensa?
Retraction, grade 1 retraction.
The glistening is not there.
Yes, loss of glistening.
No, you say retraction. How do you say that tympanic membrane is a retracted? What are the points to you consider when you say the tympanic membrane is retracted?
To the level of one, there is distortion of cone of light, sir.
Distortion or absence of cone of light. Distortion or absence of cone of light is number one.
Then compared to the annulus, the tympanic membrane appears to be at a deeper level.
Can you differentiate between the annulus and you look at this case, you can actually see the annulus. Tympanic annulus you can see as a thick band,
Yes,
especially in the posterior superior area. You can see the
band.
thickening of the annulus. Right.
Then anterior and posterior prominence of the
Prominent anterior and posterior malleolar folds. Prominent lateral process.
Then,
What about the handle of malleus?
malleus.
Foreshortening of the handle of malleus. What do you mean by foreshortening?
It is not an actual shortening. It is an apparent appearance of the handle of malleus to look short.
Apparent
Because of
short.
medial
It's an
ligament.
apparent foreshortening.
Yes.
Apparent foreshortening. Because the handle of malleus is retracted towards the medial wall of the middle ear. So these are the signs of a retraction. What are the various types of retractions and whose name the classification goes?
Sales classification, sir, for past tense retractions. Grade 1 is where there is a retraction of the tympanic membrane, and grade 2 is where there is retraction of the tympanic membrane reaching up to the long process of the incus. Grade 3, retraction of the tympanic membrane up to the promontory. But it is mobile on doing a Valsalva, sir. In case of grade 4, it is a complete retraction up to the medial wall promontory, but which is adhesive type and does not move on changing the middle ear pressure.
Retraction and adhesion are not same. right?
Yes, sir.
Retracted, all retracted tympanic membranes need not be adhesive.
Yes.
Adhesive. So how do you rule? How do you test for the adhesion?
One by doing a serialization test, sir.
One by doing a serialization. When you do serialization, what do you look for? You are
If the
increasing.
pars tensa is mobile,
You are increasing the pressure in the
external artery.
external artery canal.
Yes.
Right. If the tympanic membrane is adherent, will it move?
No, sir, it will not move.
It will not move.
It is adherent.
Right. If the tympanic membrane is only retracted,
Yes,
it
sir,
might
it
move.
might move.
It might move. But how do you definitely know that the tympanic membrane is adherent?
Ask the patient to do a Valsalva maneuver,
Can you do a Valsalva maneuver or
Toynbee's maneuver, reverse Valsalva.
reverse?
Reverse Valsalva.
You can do that, and then you know that by blowing air into the middle ear, you push the tympanic membrane laterally and see that the tympanic membrane is not adherent to the medial wall of the middle ear. That's how you look for this thing. So you have done serialization in the both ears.
Yes, sir. In the right ear, the pars placido retraction was mobile, sir.
Okay.
Then, and the pars tensa retraction could also is also mobile, sir, on serialization.
Right ear.
Yes, sir. On
Okay.
right ear.
Yeah. Now right ear level will go to the pars flaccida. That is static. What is the find? Is it normal? Abnormal?
Abnormal, sir.
Yeah. Tell what is the abnormality you are seeing there?
There is retraction of the pars flaccida, sir, with the partial erosion of the outer bony sputum, sir.
There is a partial erosion of the bony sputum, but
the membrane seems to be intact, sir. It is not a perforation. The
you mean to say it's only a retraction?
retractions.
Retraction.
The fundus can be visualized. So
You are
I
seeing
would
the fundus.
yes.
You are seeing the entire fundus? Are you seeing the entire fundus there? The part of the fundus which is under the sputum,
Yes.
are you able to see that?
No, sir.
You are not able to see that. So how best you can see that area? This is what you are looking at right now is probably an auto microscopic picture or auto endoscopic picture.
Endoscopic.
This is an auto endoscopic picture. So if you
yes,
want to
sir.
know that part of the fundus which is under the sputum,
Yes, sir.
the endoscope helps.
Yes, sir.
You can definitely go much more nearer to the fundus and look at the fundus. But as we look at it as it is, the tympanic membrane, the pars flaccida looks thinner and retracted. Again, how is the retraction of the attic classified?
Dose classification, sir. Grade 1, where there is retraction of the pars flaccida not touching the neck of the malleus. Grade 2 is where there is retraction touching the neck of the malleus. Grade 3, where there is retraction with partial erosion of the outer sputum, and complete erosion of the outer sputum is grade 4.
Here they are also seeing a part of the head of the malleus.
Yes, sir.
You are also seeing a part of the head of the malleus under the tympanic membrane. Right. Serialization.
As a serialization, the retraction is mobile, sir.
Whole tympanic membrane is moving.
Whole
Tympanic membrane is mobile. Okay, fine. So these are the findings you have got. You have got a disease on the right side. On the left side, there are signs, but there is no symptoms on the
symptoms on the
right ear, in the right ear. But definitely there are signs of a middle ear disease. Middle ear disease. Right. Go ahead.
The palpated stress, tragal tenderness. There is no tenderness noted on both the left and the right sides. The 3-finger test.
How do you do the three finger test?
I would like to use my thumb, index, and middle finger to place over the Symbaconca, body of the mastoid and the tip of the mastoid, sir. And then look for any tenderness. Symbaconca corresponds to the mastoid antrum, the tragus.
The tragus corresponds to the external canal. External canal. Symbaconca for
Symbaconca for the mastoid
mastoid
antrum.
antrum. Okay. Okay.
Then fistula test is negative on both the left and the right side.
Both fistula test is negative. Now, how do you do fistula test?
First,
What are the
explain to
different methods
patient
of doing fistula test?
Segalization,
Yeah, you can use Siegel speculum or
press over the tragus and give intermittent pressure.
intermittent pressure over the
External.
tragus. Both ways you can do a Siegel. You can do a fistula test. Fistula test is negative. Does it mean anything to you?
Yes, so there is no abnormal communication between the inner ear
Are you
and the
100% sure about it?
there could be a cholesteatoma which is covering and giving a false negative.
False negative fistula test. What are the causes of false negative fistula test?
One is a cholesteatoma
One
covering
is
the
something is blocking the fistula.
fistula, sir.
Something is blocking the fistula.
Yes. And also a dead labyrinth.
Number two, the labyrinth itself is not responding to the stimulus. Not responding to the stimulus. So both are, in both the cases, you have a false negative fistula test. False positive fistula test.
Yes, sir. Seen in syphilis.
Syphilis you don't see now, and we don't see the syphilis now.
And in Meniere's disease also, sir.
Meniere's disease, anything else? Anything to do with stapes?
Hypermobile stapes.
Hypermobile stapes foot plate. Sometimes you will be having you can have a false positive fistula test. Okay, go ahead.
Cerebellar signs are negative. There are no signs of facial nerve weakness.
Okay. Now, tell me the classification of the facial nerve paralysis. House-Brackmann's classification.
It is classified into 6 types. First is normal. Second is a mild dysfunction. Third is a moderate dysfunction, moderately severe dysfunction. Severe dysfunction and the complete paralysis of the facial nerve.
When you look at the facial nerve palsy, what are the things you look for? The patient is having a facial asymmetry. What are all the things you look for?
One, differentiate between upper motor and lower motor type of lesion.
How do you differentiate between upper motor and lower motor?
If the patient, if there is a sparing of the forehead, I would I would consider it to be an upper motor neuron, sir, because it has a bilateral innervation. And if there is a loss of crowning as well, then I would consider it to be a lower motor neuron type of lesion.
Okay. So first thing is you would like to rule out an upper motor neuron versus lower motor neuron. Then in temporal bone lesions, in all the middle ear disease, you expect a lower motor neuron facial nerve paralysis. Right. Okay. Now, if there is a paralysis, you are going to classify that. If there is no paralysis and there are no cerebellar signs, what are the tests you have done for the cerebellar signs?
Dysdialectal kinesia test, pass pointing, then Romberg's test.
Romberg's.
Heel shin test.
Okay, right. Go ahead.
Tuning fork test, Rennie's test on the left side, 256 Hz and 512 Hz and 1024 Hz are negative.
Why did you do so many tuning? Why did you use so many tuning forks?
To quantify the degree of the hearing loss.
So basically, you are doing the tuning fork test for 2 reasons. Number 1, to know the type of deafness. Number 2, degree of hearing loss as much as possible. It may not be completely quantitative, but at least we should be able to identify to certain extent. So what are the tuning forks you have used?
I used 256 Hz, 512 Hz and 1024.
512 and 1024. So what is your result?
On the left side, it is negative for all the 3 tuning forks, indicating a hearing loss of about 55 to 60 decibels.
Okay.
And a conductive type of hearing loss.
Conductive type of hearing loss.
On the right side, it is negative for 256 Hz and positive for 512 and 102 Hz.
Then it's surprising. Now, can you tell me why he is not able to appreciate his hearing loss? He has a hearing loss,
Yes, sir.
but he is not able to appreciate the hearing loss.
Uh, in left ear? In left
Le-
ear, sir?
No, in right ear. He has a low frequency hearing loss.
Yes, sir. Normal speech frequency is in the level of 512 hertz.
So that's the reason why he is not able to appreciate the hearing
Hearing
loss. Okay, fine. Now that's about Rinnis. Now Weber's
Weber's test is lateralized to the left ear.
lateralized to the left ear.
Then absolute bone conduction test, it is same as
How,
examiner.
how much difference should be there for a Weber to be lateralized?
5 decibels.
5 decibels is enough for Weber to be
lateralized.
lateralized. For Rinni to become negative,
15 decibels
15
of
decibels difference should be there between this. Right. Right. Absolute bone conduction test is
same as the examiner.
same as the examiner on both the sides. So okay. So what is your inference at this level about the tuning fork test?
It is
Qualitatively, quantitatively.
It is a conductive type of hearing loss.
It is a conductive hearing loss. You are now ruled out a
Sensory
neural hearing loss because of the
absolute bone conduction.
absolute bone conduction test is normal. Normal. It's the same as the examiner. That's the reason why you are ruling out a sensory neural component at this point of time. Right.
And coming to the degree of the hearing loss, since the left side it is limited even for 1024, which is corresponding to about 55 to 60 decibels of hearing loss. So I would consider it to be a moderate
Conductive hearing loss is your diagnosis at this point of time.
Yes.
Right. We'll keep adding to our diagnosis. Right. Go ahead.
Examination of the nose. There is a left-sided deviated nasal septum with the right turbinate hypertrophy. And examination of the oral cavity and the oropharynx. There is no abnormality.
Okay. Are you surprised with the examination of the nose findings?
No, sir. Already the patient has bilateral ear pathology, so I would suspect nasal pathology to be present.
There will be some amount of nasal
nasal
pathology will be there. Did you see the nasopharynx?
No, sir.
Is it
I would
necessary?
like to do a diagnostic nasal
Is it necessary to do is it necessary in this case to see the
Yes, sir,
nasopharynx?
since the bilateral there is pathology of both the ears, I would like to rule out any nasopharyngeal pathology.
What is the thing you are going to consider there? What pathology you are expecting in the nasopharynx?
Enlarged adenoids.
Adenoids can still be
Since
present in
childhood,
an present at this particular point, age of time. He is only hardly 25 years. So definitely you consider
and
adenoids hypertrophy also maybe contributing to the bilateral ear disease. Right. Okay. Right. Yeah, that brings you to a
clinical
diagnosis or differential diagnosis.
a diagnosis, sir.
When we finish the history, we consider two diagnoses.
Provisional working
Two working diagnoses we have considered. Number one is squamosal type of chronic suppurative arteritis media and the tuberculous arteritis media. Now, with your findings, how will you rule out the tuberculous arteritis media?
In case of a tubercular otitis media, there will be multiple perforations, sir. Presence of a pale granulations, which are not present in this case. So,
And early facial palsy. You won't wait for 12 years to become the facial nerve to be involved. So you expect that. So what is your diagnosis? Final diagnosis going to be? And before going to final diagnosis, you confirm your clinical findings which contribute to the diagnosis.
yes, sir. In case of
Summarize your positive clinical findings which contribute to your clinical diagnosis.
left side, there is a erosion of the attic. There is an attic perforation with the cholesteatoma debris collection, sir. So, and the posterior superior quadrant also is congested, and there is debris collection and granulation tissue. Then coming to the right ear, there is partial erosion of the attic with a retraction seen in the attic region, sir.
It is a grade 2 retraction.
Grade 2 retraction.
Grade 2 retraction in the attic.
Grade 3, sir.
Grade 3 retraction. Okay. So you have a grade 3 retraction in tympanic membrane with a mild conductive hearing loss.
Yes.
Mild conductive hearing loss. So now what is your diagnosis? Final diagnosis is going to be
Chronic otitis media of active squamous cell type in the left ear with moderate conductive hearing loss without any complications, and right-sided chronic otitis media of inactive squamous cell type with mild conductive hearing loss without any complications.
Okay.
Or another diagnosis I would give is a bilateral chronic suppurative otitis
yeah.
media.
There can be some old-time examiners. You need to give the both the diagnosis.
Bilateral chronic suppurative otitis media of eticoantral type with moderate conductive hearing loss of left ear and mild conductive hearing loss in the right ear without any complications.
Okay. We are now dealing with an uncomplicated squamous cell type of disease and clear-cut case of perforation, clear-cut case of cholesteatoma in the left ear, and probably a persistent or long-standing eustachian tubal dysfunction in the right ear, leading to some signs of tympanic membrane. Right. So now, what is your approach going to be? How are you going to approach this case?
First, I would like to do investigations. I would like to do an examination under the microscope, sir.
Microscope or otoscope or endoscope? Automicroscopy versus autoendoscopy. Which one you prefer? Which one you? What are the advantages of automicroscopy? What are the advantages of autoendoscopy?
Automicroscopy, both my hands would be free, so working with both the hands.
You will be able to
possible, sir. Assessment.
You will be able to
suction the.
do suction. You can do a good suction clearance.
Yes.
You can do a good suction clearance, and then assess the tympanic membrane. That's one of the advantages of automicroscopy. Here in this particular case,
since I cannot see the fundus of the right ear in this.
In the right ear, fundus of the retraction pocket in the right ear, probably the autoendoscopy will be probably be better.
Visualizing that portion.
So will it? Do you think both will be complementary to each other?
Yes, sir.
Definitely yes. So no one test will be 100% guaranteed. So both are complementary to each other. Use of an endoscope can be a complementary to, because you can go much more nearer to the tympanic membrane and look at the areas which you are not able to see in the through a microscope. Right. Okay. Number one, we would like to do a automicroscopy or autoendoscopy or whatever it is. And what do you do when you do an automicroscopy or an autoendoscopy?
First, a suction.
You can do a good suction clearance. You will be able to see all the areas clearly. Then
send if there is a collection of.
you have. We are going to talk about your case.
Yes, there is a collection.
There is a pus. There is pus in the anterior recess.
Yes, sir.
Anterior recess. So you would like to take
send that for
culture
and
sensitivity.
Sir, I don't. If I can interrupt you for a minute. Hello.
Yeah, sure. Yeah.
So there are a few questions from the audience. One, Dr. Shiva Balaji has asked us, should we include in the diagnosis left DNS with right inferior turbinate hypertrophy when you are presenting an ear case? So the answer by Professor P.S.N. Murthy would be appreciated.
Yes, it has to be included.
Okay.
Because it's the diagnosis of the entire patient, not only the ear.
Oh, okay. So so Tanai Parik has asked us a question. Inactive squamous type of CSYM diagnosis is still there in classification, or we just call it pars flaccida retraction?
Sorry, sir, I did not get your question. Hello, sir, I did not get your question, sir. Can you please repeat?
Dr. Tanai Parik has asked us a question. We have mentioned that inactive squamous type of CSYM diagnosis Is it still there in the classification, or we just call it pars flaccida retraction?
In the recent classification, it is considered to be as an inactive squamous ulcer. Retraction in pars flaccida is considered to be part of inactive squamous ulcer.
Okay, okay. Thank you. Please proceed.
Right. Now you would like to include the DNS and the
Yes, sir.
so
I would like
so
to-
that now the diagnosis will be
Chronic otitis media of active squamous cell type in the left ear with moderate conductive hearing loss without any complications, and the right-sided chronic otitis media of inactive squamous cell type with mild conductive hearing loss without complications, and left-sided deviated nasal septum with right inferior.
it is left-sided deviated nasal septum or deviated nasal septum to left.
Deviated nasal septum to the right.
Deviated nasal septum to left.
Left side.
Okay, right.
And the right-sided inferior turbinate hypertrophy.
Is it because of the deviation or because of the disease? Is it because is it a compensatory hypertrophy on the other side,
Yes, sir, it is a
or is
compensatory
it because of a disease?
It is a compensatory hypertrophy because of the deviated nasal septum to the left side. The right side becomes compensatorily hypertrophy.
You're not considering any other disease in the nose.
Allergic rhinitis also could be a cause, sir.
Anything else? A deviated nasal septum with the persistent hypertrophy of the nasal, of the
Turbinates.
turbinate.
Chronic.
Chronic
Chronic
rhinitis or chronic
chronic
rhinosinusitis also need to consider because he has symptoms.
Yes, sir.
He also has symptoms of nasal disease.
Yes.
So you also consider a chronic rhinitis or a chronic rhinosinusitis, and you need to investigate for the
For
that also. So
pathology,
please, that also you keep in mind. Okay, now we have now done with an automicroscopy or an autoendoscopy, and then
Then
you
I
have
would
taken pus or discharge for
culture and sensitivity.
culture and sensitivity. Is it important for you, the culture and sensitivity, and
Yes.
how does it help you?
In the postoperative period to give the right antibiotics for the microbial organisms, it would be helpful.
Inevitably, the result with the report will come as an anaerobic organism, Pseudomonas, and so will it really help you? And then probably the report says it's only sensitive to gentamicin and amikacin. Are you going to give these antibiotics in the postoperative period?
No, sir.
No, you are not. It's going to tell you what sort of an organisms are there, because normally there are several commensals which occur in the external canal. So you don't consider all these things into real this thing, but it will help you to, if you find an unusual organism, then probably you will look for the
Choice,
sensitivity.
choice.
Okay, right. Anything else now? Next what?
Next, I would like to get a Puton audiogram, sir.
Next, you would like to do a pure tone audiometry. Right. Why do you want to do a pure tone audiometry?
One for the documentation purpose, sir.
Number one, documentation purpose.
And to confirm my tuning fork test by getting the type of hearing loss and the degree of the hearing loss.
Okay. You want to confirm your diagnosis by pure tone audiometry. So you would like to know whether it's only conductive hearing loss or a sensory neural hearing loss or a mixed hearing loss. Okay. No. Right. Is there still possibility of having a mixed hearing loss in this case?
Yes, sir.
Still, that possibility is still there because you have stopped only at 1024.
Yes.
Beyond that, you haven't tested. So there's still a chance of high frequency sensory neural hearing loss still is a possibility in the case. So you have to keep that also in mind. Right. Now, you have done a pure tone audiometry. And how much hearing loss you are expecting? According to your tuning fork test, how much hearing loss you are expecting in this?
About 60 decibels of hearing
About
loss.
60 to 70 decibels of hearing loss.
In the left ear, and 25 to 20 to 30 decibels of hearing loss in the right ear.
Okay, right. Will you be surprised if you get a mixed hearing loss in the left ear?
No, sir.
No. Right. Agree. Okay.
Then I would like to go ahead with doing a HRCT temporal bone, sir.
You would like to do an HRCT temporal bone. I mean, tell me one or two reasons why you want to do HRCT temporal bone and not an X-ray mastoid. Are you against X-ray mastoid?
In this case, HRCT gives a better detailing than plain X-rays.
Than plain X-rays, right? Okay. You have taken an HRCT temporal bone. What is the first thing you are going to look for in this case?
Patient of ossicular chain mastoid disease. Pneumatization of the mastoid.
That's what is more important. First thing what you are going to look for is the pneumatization of the mastoid here. Why is it significant?
Since the patient has the chronic ear discharge, so there will be poor pneumatization of the mastoids.
Will you be surprised if you see it's a pneumatized mastoid? If you see a pneumatized mastoid in this case, will your diagnosis going to change?
No, sir.
Or the management is going to change?
No, sir.
Sure. Management may not change. The pathophysiology will change. The pathophysiology is going to change because it will become a cholesteatoma in a pediatric population, which is much more aggressive than an adult cholesteatoma. Because the disease started somewhere at 12 years. The disease started with a nasal disease. He has got a bilateral ear disease and a nasal disease. So, and the disease started very early in life. So probably it might have occurred also on a pneumatized mastoid. So that also you need to keep in mind. So first thing you are going to look for in a HRCT is
The
degree of pneumatization. Right. Okay. In this case, you may find both the sides you may find
pneumatized.
you may not find a pneumatization on both the sides because the disease is there since quite some time. How will you differentiate between a primary pneumatization or a primary sclerosis, primary sclerosis and an acquired sclerosis? Both sides you are seeing a sclerotic mastoid. But how do you know whether this mastoid is sclerotic from the beginning or it became sclerotic because of the disease?
And sinodural angle.
You look at the dura and the sinus plates. The dura and sinus plates will be, if it is a secondary sclerosis, the dura and sinuses will be you will see large mastoids with sclerosis in the center. So primarily the mastoid is pneumatized. It became secondarily sclerotic. So the dura and sinus plates will be at normal positions. Whereas in a primary sclerosis, the dura and sinus plates are going to be very nearer to the external artery canal. Nearer to the external artery canal. That is how you differentiate between a primary sclerosis and a secondary sclerosis. Okay. Then what are the other things you look for in the CT scan?
The status of the ossicular chain.
The status of the ossicular chain. So what are these?
Erosion, if there is any erosion of the ossicles, since the patient has almost 60 degrees of hearing, 60 decibels of hearing loss.
No, you are going to look at one particular point. What is the point? What are you going to look at? Which?
The ice cream cone appears.
The ice cream cone appears. Now, in this case, in the ice cream cone, what is missing?
The cone.
The head is not there in that. The head of the malleus is all clinically itself. We are not seeing the head of the malleus. So, radiological also we will find that the head of the malleus may be missing, right? So that is one thing which you look for in the ossicular chain continuity is one thing which you are going to look for. Then
any
erosion of the scutum. Actually, clinically itself we are seeing the erosion of the scutum in this case. So the CT may not give you more information than that.
Then the fallopian canal of the patient.
Facial nerve. You can nicely completely trace the facial nerve and see whether the The,
Any bony
the
erosion.
bony erosion of the canal is there. There's no paralysis in this case, right?
No, sir,
No paralysis, no paralysis. But then why in that case, why are you looking at the facial nerve?
If in intraoperatively, if it is dehiscent, then
You will be careful when you will be very careful when operating on a dehiscent facial nerve. So you would like to know whether the facial nerve is dehiscent or not. Then
Just a small interruption, sir.
yeah.
Interesting point you raised. That is the difference between primary and acquired sclerosis seen. Can you repeat that for the sake of audience? Because many people are asking that. It's a very new point. And can you please repeat it?
Actually, Janki, is not a new point. It's there in the old textbooks, not the new textbooks.
Okay. Can you please repeat it? Because Dr. Momita Sen, so many people are asking. Maybe they want you to reinforce that point. Please tell me.
If the mastoid is normally pneumatized,
Okay.
both the mastoids are pneumatized, and then it is sclerosed because of the disease. You will see the sinus plate and the dural plate at the normal positions.
Okay.
If the sinus plate and the dural plates are very nearer to the external artery canal,
Okay.
that usually indicates that primary sclerosis.
Oh, okay. Thank you, sir. Thank you. Please carry on. Yeah.
So, yeah, where are we?
I've also looked for the anatomical variation.
Anatomical variations of
The forward lying sigmoid, low lying dura.
by any chance, are you going to ask only CCD temporal bone, or you are also going to ask as per a CT brain?
CT brain, since the patient do not give any history of an intracranial complications, I would not consider.
You would not consider that. You would not consider having. Okay. Any other investigation you would like to do?
I would like to do a diagnostic nasal endoscopy. Sir,
Absolutely right. You need to do a diagnostic nasal endoscopy. And what do you expect to find?
A large adenoid hypertrophy could be a cause, sir, which is present since childhood.
Do you think the adenoids are the primary cause?
It is a possibility.
You have something else in front.
The chronic sign.
You have a deviated nasal septum. You also have the hypertrophy turbinates. Definitely, it indicates that there is an infective process in the nose also.
Yes.
Nose. So you look for the sign, any telltale signs of
Chronic
rhinosinusitis. Like this, you look for mucoid or mucopurulent discharge. You look for. Okay, right. And then adenoids.
Yes.
Right. Okay. Done that. Would you like to investigate the nose and paranasal sinuses further?
Yes, sir.
Definitely in this particular case, definitely we would like to do a CT scan of the paranasal sinuses to look for the disease in the ear. Okay, you have done that. Now summarize the investigations which you have done till now.
One examination under microscopy.
Microscopy, right?
Then two puton audiometry, sir.
Puton audiometry.
Then HRCT
HRCT temporal bone.
Then diagnostic
Nasal endoscopy.
If necessary, CT paranasal sinus.
If necessary, you have to do a CT paranasal sinus in this case. Definitely. Bilateral ear disease.
Yes, sir, I would like.
Bilateral ear disease and symptomatic nose and also findings in the nose. So definitely you would like to do a CT scan of the paranasal sinuses. Now, okay. Any other investigations you want to do?
General workup of the patient.
You need to do a general workup of this patient mainly for the sake of this patient is likely to go for surgery or no?
Yes, sir, likely to go for
He is likely to go for surgery. So in that case, you would like to investigate him for a completely for a general anesthesia. So what investigations in your hospital you do for general workup of this patient?
Complete blood picture. Sir.
Complete blood picture.
Then kidney function test.
Okay, 25-year-old man. He comes under which ASA grade? He has no comorbidities, so it almost comes as ASA grade 1. So you don't require many investigations, but you better, in the present scenario of diabetes mellitus occurring in very young people, you would like to rule out the diabetes mellitus. Okay. All right. Now what? Now what?
I would like to take up the patient for surgical. I would like to take out the first-
How will you counsel this patient? What are you going to tell this patient about the treatment options? What are the treatment options, and how will you explain to the patient what are the treatment options?
One, the hearing. I would like to, that the disease is unsafe and
It is
the
an
disease
unsafe.
has to be
Unsafe means
cleared out.
what exactly you mean by an unsafe disease?
There is the chance of going into complications, sir. It is an erosive type of disease. It is destructive.
Disease. So the chances of this patient getting complications is higher. So you want to make the patient
Make the ear safe.
make the patient safe, not the ear safe.
Yes, sir.
Here you want to make the patient safe, because patient is a danger at all, not the ear. All right. That is your aim is you want to make him a safe patient, because without any chance of the infection going into the important structures, brain or whatever it is. And so that's the first thing you tell the patient. Next.
Then about the hearing, sir, there is a chance of further worsening of the hearing, as he could be a cholesteatoma hearer. And
So you first tell him that.
there is a chance.
What will you tell him? About number one, he has come to you with two complaints.
Yes.
Number one, he has come to you with ear discharge, and then he has come to you with decreased hearing. So these 2 points, how are you going to counsel him? Now imagine I am the patient. How will you tell me?
The disease is unsafe, so I would like to take up for you need to get a surgery, and two, there is a chance that the hearing can get worse, but however we would like to reconstruct it and bring back reconstruct the ossicles and
No, you have to tell him that there are 3 tiny ossicles in the middle ear, and these 3 tiny ossicles are also probably are destroyed in the
disease.
because of the disease process. So they need to be replaced. We'll try to do replacement, but we cannot assure that the hearing may improve completely normally. We'll try our best. What about his ear discharge? What will you tell him about his ear discharge? My question as a patient is, will I have ear discharge after the operation again?
Yes, so for a few weeks they will.
For a few weeks,
they'll be discharged.
the patient can have ear discharge, but in a well done surgery, the ear becomes
Dry,
completely dry. So, what is your aim of treatment in this patient?
One, to make the patient safe.
Number one is to make the patient safe,
To make the ear
to
dry.
make the ear dry. So the main thing is ear discharge. So you want him to have a dry ear,
Dry.
right? And third one is,
Third, to try to restore the hearing.
if you cannot restore the hearing,
Use a post-operative hearing aids.
no. If you cannot restore the hearing, at least preserve whatever hearing he has got. You preserve whatever hearing he has got, and also if you can improve the hearing, well and good. So when you are counseling the patient, you tell them about these 2 things, and also one more important thing. What is that?
Take a consent for facial paralysis.
Not consent for facial paralysis.
Facial nerve.
Tell him that the facial nerve is at danger, at risk, because it runs inside the middle ear, and nerve is at a risk. That's what you are going to tell him. You are not going to tell him that the patient is going to have a facial nerve paralysis. You are mentally preparing that there could be a chance of facial nerve paralysis. Right. Okay. Now, with this, you have explained to the patient has agreed for surgery. Now, what is your plan of surgery? What are you going to operate on the nose? Are you going to operate on the right ear? Are you going to operate on the left ear?
First, I would like to to ear. I mean, if the unsafe ear, left ear,
You already diagnosed the unsafe ear in the left ear, so the priority goes to
left ear,
left ear,
surgery.
not the. Though even though the nose is the starting point of the primary pathology, we are not going to touch the nose at this point of time. Right. You found cholesteatoma. Can you tell me how do you define cholesteatoma?
It is a three-dimensional connective tissue and three-dimensional connective tissue with connective tissue and epidermal structure, usually in the form of a sac, confined to the spaces of the middle ear, and has the propensity to expand at the expense of the underlying bone, and also has a tendency to reoccur even after removal.
How does it destroy the bone?
One by enzymatic action, sir.
Enzymatic action.
Two by pressure necrosis.
By pressure necrosis.
And three by
Cholesteatoma per se will not cause osteitis. Cholesteatoma per se will cause only preformed pathways. A secondary infection will cause the complication. Will cause the complication. Not the cholesteatoma per se will not cause a complication. It only creates preformed pathways. Right. So one is enzymatic destruction. The second one is a pressure necrosis. These are the two common causes of the cholesteatoma. How it destroys the surrounding structures. What are the types of cholesteatoma you know?
congenital cholesteatoma,
Congenital cholesteatoma,
primary acquired cholesteatoma,
and secondary acquired cholesteatoma. What are the characteristic features of congenital cholesteatoma?
whitish appearing mass behind an intact tympanic membrane. Sir.
It has to be an intact tympanic membrane.
Then patient, there is no prior history of ear discharge.
There should not be any history of ear discharge.
And no history of otological surgeries. Then
Why surgery can cause cholesteatoma?
yes, sir. Secondary acquired cholesteatoma is possible with the history of prior history of surgeries.
How? What is the pathophysiology behind it?
The squamous epithelium, which is
Any squamous epithelium getting entrapped in the middle ear, and you close it by a graft. So that can cause a secondary acquired cholesteatoma. Here, there should not be any prior history of any surgery on the ear. So these are all the characteristic features of a congenital cholesteatoma. What are the sites of congenital cholesteatoma? Congenital cholesteatoma can occur anywhere in the temporal bone. Because congenital cholesteatoma also comes in the differential diagnosis of another condition. Petrus apex. Yes, also can usually it also mimics a cerebellopontine angle tumor. So it can also occur in the Petrus apex. It can occur in the middle ear. But whatever said and done, it has to be an intact tympanic membrane. Tympanic membrane should be intact to call it a congenital cholesteatoma. All right. Okay. Primary acquired cholesteatoma and secondary acquired cholesteatoma. What is primary acquired cholesteatoma? And before that, would you like to tell me about the theories of cholesteatoma?
Yes, sir. Invagination theory, implantation theory, metaplasia, and basal cell hyperplasia.
Hyperplasia, right. When you tell how these theories can affect and cause primary and secondary acquired cholesteatomas.
Primary acquired cholesteatoma could be an invagination theory.
Primary invagination theory usually starts with a
retraction formation and then going into.
What is the cause of retraction?
Eustachian tubal dysfunction.
Primarily starts with an eustachian tubal dysfunction. Middle ear ventilation is affected. Middle ear ventilation is affected, and then finally it leads to a retraction, which leads to
retraction pocket and collection of cholesteatoma debris.
Collection of epithelial debris. Epithelial debris, which finally become a cholesteatoma. Right. that usually have the usual something like a primary acquired cholesteatoma. Or the other theories, even the basal cell hyperplasia also can occur. Basal cell hyperplasia usually occurs in which type of cholesteatoma? Which region usually basal cell hyperplasia occurs?
Attic.
It can occur both in the attic and posterior superior quadrants. And the basal cell hyperplasia is more seen in the posterior superior,
Quadrant.
more seen in the skin of the epithelium of the posterior superior canal wall has got this basal cells, and that hyperplasia is one of the causes for the primary acquired cholesteatoma. Then what is secondary acquired cholesteatoma?
Secondary acquired cholesteatoma, which occurs secondary to a perforation, sir, either due to an implantation theory or by metaplasia.
Metaplasia, either squamous metaplasia can occur, or it can be an implantation of the epithelium into the middle ear. That is how a retraction pocket becomes a cholesteatoma, or a large perforation can become a can cause cholesteatoma. What prevents the epithelium to go into the middle ear?
The annulus.
The annulus prevents the epithelium migrating into the middle ear. So if there is any breach of the annulus, usually in the posterior superior quadrant and in the superiorly in the attic region, there can be second acquired cholesteatomas occur. Right. Okay. That's about the pathophysiology of the cholesteatomas. Right. Now in this case, what are you going to do?
I would like to take up the patient for a left-sided ear, sir, master.
Left is you want to take this patient for surgery,
Yes.
and what surgical procedure you are going to do, and what surgical procedure you are going to tell the OT nurse to be ready with.
For modified radical master.
Your aim of doing surgery in this patient, or your aim of treating this patient is, number one, to make the patient safe. Number two, to make the ear dry. And number three, to preserve hearing or to improve the hearing. Keeping these three things in mind, what is the surgical procedure you are going to do?
I can all wall down mastodectomy.
No, what is the surgical procedure you are going to do in the?
Modified radical mastodectomy.
That is the procedure. Basically, you want to explore the mastoid and see the disease.
Yes. Mastoid exploration.
You explore the mastoid first. Mastoid exploration, and do whatever type of mastoidectomy you want to do. Then?
And then restore the
To restore the hearing, you need to do?
a tympanoplasty.
You need to do a tympanoplasty. So finally, you will end up doing an exploratory mastoidectomy with the tympanoid. You are only exploring the mastoid, or you are exploring the middle ear also?
Middle ear along with the
You are exploring both the middle ear, going to follow the disease wherever the disease goes, and then remove the disease. Remove complete disease. That's what we call it as exenteration of the disease. Remove the disease. And then
restore the hearing
by doing some sort of a reconstructive surgery. That's what is the aim of your aim of surgery is going to be. Whatever name you are going to give to this is fine. But basically, what you are going to do is you are going to explore the middle ear and the mastoid, exenterate or excise the entire disease, follow the disease wherever the disease goes, remove the complete disease. Once the disease is removed, you also do one more step.
I would like to do a meatoplasty.
You do a meatoplasty. By doing a meatoplasty, what are you doing?
Trying to exteriorize the cavity.
You are trying to exteriorize the cavity what you have made, so that there is no hidden areas, there is no hidden collections, there is no, because all the complications are occurring because the whole disease is hidden. So you are not going to hide the disease. The disease is going to be exterior. I mean, the area is going to be exteriorized. The area of middle ear and the mastoid are going to be exteriorized. And then do a reconstructive procedure to improve the hearing. Right. So we'll take it in this manner. So we are going to explore the middle ear and mastoid first. Right. Now, what are the different methods of mastoidectomies? You know.
Inside out mastodectomy.
No, that is how
Cortical mastodectomy.
you do cortical mastoidectomy,
Modified radical mastodectomy.
modified radical mastoidectomy, and a radical mastoidectomy. Will you consider cortical mastoidectomy in this case?
No, sir.
No. You are not going to consider the cortical mastoidectomy in this case alone because you are going to explore both the middle ear and the mastoid you have to explore. So to see the entire middle ear and mastoid, what do you need to do?
A canal wall down procedure, sir, where
So you have two options.
eticoantrostomy and then
No, you have two options. One is keep the canal wall intact and look at the middle ear and the mastoid
yes,
underneath that.
yes, sir.
Or remove the canal wall and look at the entire middle ear and mastoid as one single cavity.
Yes, sir.
As one single cavity. So you have two options. The options are intact canal wall or canal wall down. So you have two things. So you have three types of mastoidectomies: cortical, modified radical, and radical mastoidectomies. Out of which cortical mastoidectomy you are not considering now. And then second thing is to look at the entire middle ear cleft. Now we are now talking about entire middle ear cleft. So you have to look at the entire middle ear cleft. You need to either remove the posterior canal wall or you need to look with the canal wall intact both the sides and remove the disease process. Right. Now keeping in this mind, what are the soft tissue approaches to the mastoid? Basically, unless you cut the soft tissues, you cannot reach the bone. So what are the soft tissue approaches?
Post-auricular.
One is the post-auricular approach,
Then a Lefferts
endoral approach,
then a transcanal.
and transcanal approach. So in these are the three methods. Out of these three things, which one you prefer?
Post-auricular.
You are comfortable with post-auricular approach, right? It gives you good access. It gives you a better access than but there are people who are very comfortable with the endoral approach also. Right, okay. Now second, the next option is going to be, once you have taken the soft tissues out of your view, now you are going to look at the entire extraordinary canal and the mastoid bone. Now you have to again decide between the inside out, between intact canal wall or canal wall down. So in this particular patient of 27 years old patient, what type of mastoidectomy you would like to consider?
An inside out mastodectomy.
Are you sure? We have also said this patient is likely to be a pediatric cholesteatoma with a pneumatized mastoid. The possibility of a pneumatized mastoid is still there. So in that case,
Outside
you can start doing a mastoidectomy and then remove all the disease in the mastoid, then come into the middle ear and then remove the middle ear disease also. There are people who do a inside out technique also, but you need to probably do a good take away a lot of bone because if it is a pneumatized mastoid. So you have to be prepared for that and that preparation will come from your CT scan. Once you see the CT scan or the X-ray mastoid, definitely you will know whether where exactly is how much pneumatization is the mastoid. Right. So either you are now opting for a canal wall down technique.
Yes.
Yeah. Is there any specific reason why you are opting for a canal wall down technique?
Since it is a cholesteatoma
If you plan to keep the canal wall intact, what are your options? How will you remove the middle ear disease? Actually, what are the hidden areas of the middle ear from
Sinus,
where the disease has to be removed? Otherwise, it is going to
sinus tympani is
sinus tympani and
the anterior attic facial recess.
anterior attic facial recess, anterior epitympanum.
Anterior.
And below the anterior epitympanum, you also have one more space,
Supratubal space.
supratubal recess. These are the areas where the cholesteatoma can be hidden. So all these areas have to be cleared. So how will you enter into how will you start from the epitympanum? How will you start from coming from the mastoid into the middle ear?
From the epitympanum, I would like to
If you are working from the epitympanum, you do a,
anticoanthropotomies first. Sir,
you
and
keep
then
removing the scutum and keep removing and going towards the mastoid antrum. That is if you are operating from the canal inside out. If you are operating from the other side,
first open the mastoid antrum and follow the disease anteriorly through the adductus and then into the attic and then into the middle ear.
you can still remove the posterior, you can still do a posterior epitympanotomy. You keep removing the bone towards the zygomatic process, and then you will see the entire posterior part of the epitympanum through the mastoid. That is in the epitympanum. How will you see the disease in the mesotympanum?
I would like to remove the anterior buttress, the posterior buttress, and
No, we are talking about intact canal wall. We are keeping the canal wall intact. If you are going to remove the anterior buttress or posterior buttress, you are removing the entire posterior canal and making the whole thing into one large cavity.
I will do a posterior tympanotomy, sir.
You will have to do a posterior tympanotomy. What are the boundaries of which area you are going to do a posterior tympanotomy?
Facial recess.
Facial recess. What are the boundaries of the facial recess?
The short process of the incus superiorly, the facial nerve deep, and then superiorly the fossa incudus, and then inferiorly the facial nerve.
Do you know the other name for the angle? This angle? They actually called as cardofacial angle.
It's a chorda tympanoid nerve laterally.
Cardofacial, between the chorda tympani and the facial nerve and the
Superiorly the fossa incudus.
fossa incudus. So you do a posterior tympanotomy. What are the other surgeries you do for the with posterior tympanotomy?
Cochlear implantation.
Cochlear implantation usually you do with the posterior tympanotomy. So you can do a posterior tympanotomy and clear the disease in the middle ear, mesotympanum, especially in the
Posterior
sinus tympani and lateral and the facial recess. So you are going to clear all these areas through these two approaches. So if you are not removing the canal wall, that's an intact canal wall. But you are opting now for a canal wall down. Again, I asked you the same question. Why are you opting for an intact canal wall technique in this case?
Intact canal.
I'm sorry. Canal wall down technique in this case. The pathology is, what is the pathology in this disease? What are you going to find in the middle ear and the mastoid in this case?
Cholesteatoma.
And what is the dread thing you are seeing there? You are seeing congested thing. You are seeing granulations. You are also going to find granulations. You are going to see granulations. You are going to see the cholesteatoma. In a cholesteatomatous, here is it. Do you think you will be able to remove the entire cholesteatoma through an intact canal wall technique? No, difficult. So the reason is, and another disadvantage of doing intact canal wall technique is the patient needs long-term follow-up. Patient needs for long-term follow-up, and in India the problem is patients won't come back for the surgery. So the treatment which you are going to give should be a complete treatment. So that's the reason why you are preferring an canal wall down technique in this case. Right. You have done a canal wall down technique. You have done the You are done. You remove the canal wall. Now you are seeing the entire disease, entire cholesteatoma in the in the middle ear, epitympanum, and mastoid. So you are going to remove the entire disease. Suppose if the disease is, even in this case, the malleus is anyway it's not there. You are not seeing the head of the malleus. But sometimes if the disease is behind the malleus, head of the malleus, what do you do?
Like remove the incus and then.
No, disease is behind in the epitympanum, behind the ossicular chain. Both malleus and both head of the malleus and includomalleolar joint is intact, but the disease is behind the cholesteatoma is extending behind the ossicular head chain. You have to nip the head of the malleus. You know there is an instrument for that.
Mouse.
Malleus
Malice
nipper. There is a malleus nipper with which you can nip the head of the malleus and remove the head of the malleus and then remove the entire cholesteatoma from the epitympanum. Right. Now the same thing also to follow the disease in the mesotympanum. Remove the disease completely. Now once you have removed the entire disease, now what are you going to do now? You have removed the complete disease. You are happy that the entire disease is totally cleared from the middle ear and the mastoid. You are seeing all the areas and you do the drilling till you see a glistening white bone. The glistening white bone is a normal bone. So till you see the glistening white bone, you are going to remove all the osteotic bone. All that osteotic bone you are going to remove, and then now you have done a canal wall down surgery. You have removed the disease. Now your next plan is
To do a metaplasty.
you do a metaplasty.
First, an ossicular reconstruction.
Metaplasty is the soft tissue metaplasty. You are removing the part of a cartilage. If you are removing the part of the cartilage, it becomes a conchometaplasty. Otherwise, normally, if you only remove the posterior canal wall skin, it is only a metaplasty. If you want a wider cavity, you do a conchometaplasty. Right. Then
Middle ear reconstruction.
Then you do a reconstructive procedure to improve the hearing. What are the three areas which need to be reconstructed?
One, the tympanic membrane.
One is the tympanic membrane.
Then the ossicular chain.
Then number two is the ossicular chain.
The posterior canal wall.
Posterior canal wall also need to be reconstructed. Now, the question is, why do you want to reconstruct the posterior canal wall?
To maintain the depth of the middle
To
ear.
maintain the depth of the middle ear. What are the prerequisites for a successful tympanoplasty? Or for a normal hearing, what are the prerequisites?
Good eustachian tubal function.
Eustachian tubal function.
Air in the middle ear.
Ventilated, air-filled middle ear cavity.
Then good cochlear reserve.
Good cochlear reserve. Mobile tympanic membrane and functioning ossicular chain. Functioning ossicular chain. These are the things you have to have these are the 5 things you need for a good hearing. Or when you restore the hearing also, these are the prerequisites. Starts with a good cochlear reserve. That means there should not be any sensory neural deafness. Then number 2 should have a functioning ossicular chain. Number 3 should have an intact mobile tympanic membrane. And number 4, you need a good eustachian tubal function. And number 5, ventilated middle ear. There should be air in the middle ear. So the middle ear depth of the middle ear has to be maintained. Because the ratio between the tympanic membrane and the ossicular chain should be maintained. So now, keeping these things in mind, how are you going to proceed? In this particular case, you are operating now. You have removed the disease. The head of the malleus is not there. The posterior, the incus head, the body of the incus is there, but there it's completely filled with granulations and cholesteatoma. and you have to remove the entire incus.
Remove the incus, sir.
Because the whole of the posterior superior quadrant also you are seeing the granulations and cholesteatoma there. So probably the disease is there also. Disease is entering into the mesotympanum also. The disease is not only is in the epitympanum, it's also in the mesotympanum. So now you remove all this disease. You have done a canal wall mastectomy. You have removed all this disease. The incus is gone. Incus is either come destroyed or incus is gone. Or we have removed the incus for access. Three things. Either it is destroyed on its own, or we have removed it for the sake of access, getting access and getting clearance. We have removed that. Now the next thing, what you most important thing, what you are going to look for is the stapes. Stapes. And what are again? There is another hidden area where the cholesteatoma can still be there. Sinus tympani is there. Footplate of the stapes. Sometimes the matrix can be covering the footplate of the stapes, or the malleus, the stapes head superstructure of the stapes also may be absent. So we'll take each of these conditions and tell me how we are going. What type of reconstructions can be done. You have a handle of malleus intact, and the superstructure of stapes is intact with the mobile stapes.
I'd like to use a partial ossicular.
Number one, you can use a partial ossicular. No, head of the stapes is still intact. Okay, you can use a partial ossicular replacement process, or simpler reconstruction.
Cartilage.
You can use cartilage. Are you against preserved ossicles?
Yes, sir. Reshaping the incus.
No, not the same incus. Are you going to use the same incus?
No, sir.
It is already filled with, completely covered by the cholesteatoma. This incus. Are you going to use this incus? No, you are not going to use this incus. Not the autograft. It's going to be a homograft incus. Preserved ossicle, preserved cartilages. Which cartilage piece usually you preserve?
The septal cartilage.
Septal cartilage, nearer to the spur.
Yes,
That is the thicker part of the cartilage. That is the area. That is the cartilage you preserve for ossicular replacement. Okay. Now, suppose there is no the handle of malleus is there. There is no superstructure of the stapes. Will you remove the handle of malleus or retain it?
Retain
the handle of malleus. You are retaining the handle of malleus not for the hearing sake, for sake of
mobility, maintaining the depth of the.
For maintaining the depth of the middle ear, you can keep the handle of malleus intact, and then reconstruct with the ossicular replacement process. Okay. Then you need to reconstruct the tympanic membrane. You need to reconstruct the ossicular chain. You need to reconstruct the posterior. So, what are the materials you use for the tympanic membrane reconstruction?
Temporalis fascia, sir.
Temporalis fascia.
Vein graft.
Vein graft is too thin.
Facial eta can be used.
You may need to make another incision. What are the advantages of temporalis fascia? Why do we prefer temporalis fascia more than anything else?
From the same region, from the same incision, we can.
You can use it from the same incision. You can harvest the graft from the same incision.
The thickness is similar to.
The tympanic membrane. Basal metabolic rate is also low. So that's the reason why we use a local, very local available graft. So we use this graft. One thing is temporalis fascia. Any other graft you can use?
Periosteum. Tragal pericardium.
Tragal pericardium. You can use tragal pericardium for the reconstruction. Right. So these are basically, of late, more and more people are using. Are you against using cartilage for the grafting?
It's a cartilage.
Cartilage, tympanoplasty.
Yes, sir. Can be.
Yeah. Nowadays, a lot of people are using cartilage for the tympanic membrane grafting also. Right. Okay. So that's how you reconstruct the tympanic membrane. You reconstruct the ossicular chain, and you need to increase the depth of the middle ear. You need to have
Intact posterior canal.
you need to increase the posterior canal wall. So what material you'll use for this? For increasing the posterior canal wall? I mean,
The removed portion of the posterior canal wall can be replaced again after the disease clearance, sir.
it's all cholesteatoma. Why do you want to use any of those things? Actually, there is a procedure actually where you can take out the entire posterior canal wall as a one single piece
And then replace.
and replace it. But we are not talking about it. We don't.
Hydroxyapatite.
Cartilage. You have a lot of cartilage available in the human body. Again, the most common, very commonly you have available is the tragal pericardium or the conchical cartilage. Any of these cartilages can be used to increase the height of the middle ear. And then put the graft on put the temporalis fascia graft over that raised posterior canal wall, so that you maintain the depth of the middle ear, so that you will have a air-filled middle ear cavity. So two purposes are served here. One is raising the middle ear cavity to have a air-filled cavity, because air is a good transmitter for the sound. So three regions you are going to reconstruct: posterior canal wall, the tympanic membrane, and then the ossicular chain. This now, what is going to happen to the rest of the cavity? That means whatever the middle ear cavity, middle ear and mastoid, you have made into one cavity now. A part of this cavity you are covering with the tympanic membrane, which is connected to the eustachian tube. That means you are trying to maintain the ventilatory function of the middle ear to certain part of the cavity which you have prepared. What is going to happen to the other part of the cavity?
It will be exteriorized.
This will be exteriorized
by doing a metaplasty.
So in due course of time, what is going to happen there?
It will be squamous epithelium.
It will be squamous epithelialized. The whole cavity is going to become squamous epithelialized, but it will be still a large cavity. And this whole squamous epithelial cavity is exposed to the external auditory, through the external auditory canal, it is exteriorized. So you are doing exenteration of the disease, exteriorization of the cavity, and then reconstruction of the conductive hearing mechanism. Not everything, only conductive hearing mechanism is being reconstructed. So these are the three steps in doing this in a exploratory mastoidectomy and a tympanoplasty. This is what you are going to do the procedure. That means you are creating two cavities here, right? There is a one cavity which is covered by the tympanic membrane, which is ventilated by the middle ear, by the eustachian tube, and the second cavity totally epithelialized and exteriorized, totally non-functioning. This is non-functioning part of the ear. That is going to be the functioning part of the ear. So, do you need this much of a large cavity which is epithelialized? And what are the problems of the cavities? Mastoid cavity.
Large cavity, there will be discharging.
4 Ds.
Yes, sir.
The so-called 4 Ds of deafness, discharge, dizziness, dependence. Because this needs to be clean. This cavity needs to be clean a long time, because unless it becomes self-cleaning cavity. A large cavity is unlikely to become a self-cleaning cavity. That's the reason why now the promotion is smaller cavities, or they make the large cavity into a small cavity. So what? How do you make this large cavity into a small cavity?
I can use the obliteration techniques of
There are
mastoids.
obliteration techniques by which you can obliterate the large mastoid cavity. So what are the common thing?
One, the
Common
bone dust
tissues.
that has been removed can be used.
You can use the bone pate, bone dust. You can use the same thing can be replaced and made into a smaller cavity, or you can use lot of soft tissues which are around the
ears.
Around the ear. All these soft tissues can be pushed into the mastoid to make it into a smaller cavity, right? Okay. Now this is so instead of that, how can we reduce the cavity?
By doing an inside
By
out
doing an
technique,
inside out technique, and the disease is limited,
then
you
only
don't
that part
require
is
this much of a this thing. You will need require, you are going to put this thing. Now, basically what you have done right now is a modified radical mastoidectomy and a temporoplasty. All right. Now, suppose the disease is extending. Yeah. Yeah, Janki.
No, sir, no. I have no questions. You can carry on, please.
Oh, yeah, another 10 minutes we'll close, right?
No. You can take your time, sir. We are enjoying it.
Now, now what we do is you have done the mastoid, modified radical mastoidectomy, and you are going to put the graft. Now, suppose this patient has got a hearing loss of 80 decibels, and the patient has got a mixed hearing loss. Will your treatment going to change?
I would consider a post-operative hearing aid.
Will your treatment surgery is going to change? Will there be any change in your surgery? No? Will there be any change of your surgical technique? There will not be much change of your surgical technique because you are still trying to reconstruct the hearing. At least, definitely we will do that because still at least the conductive element can be
preserved to an extent.
Conductive element, at least you can take care of the conductive element and some improvement of hearing can be there. Somebody who is not able to hearing conservational voice, if he can hear the conservational voice itself is a good thing. So you still do the same thing. Now I'll change my question. This patient is having a sensory neural deafness. He has a 90 decibel hearing loss. So what are you going to do? What is the difference between radical mastoidectomy and a modified radical mastoidectomy?
The middle ear reconstruction is not done in case of
you don't reconstruct the middle ear. Don't reconstruct the tympanic membrane.
I mean, the ossicles are not reconstructed.
You don't reconstruct the ossicles, but you still reconstruct you still put a tympanic membrane. You still put a graft. This graft here, you are putting the graft for some other purpose, not for sake of hearing.
To cover,
to felicitate healing. Otherwise, you are going to exteriorize the mucosal area. A lot of mucosal surface in the middle ear is going to be exposed. That will again cause persistent ear discharge. Persistent ear discharge. So you don't want persistent ear discharge. The patient has come to you for treatment of discharge. You don't want discharge. So you still put a graft. This graft is not meant for hearing here. The graft is meant mainly for sake of covering the raw area so that the healing becomes faster. The healing becomes faster. Suppose this patient has got the same hearing, and what type of hearing aid you are going to give him? If you have to give a hearing aid, what type of hearing aid you are going to give him?
Bone-anchored hearing aid.
Probably you need to give him a bone-anchored hearing aid. I think Janki will stop here.
Yes, sir. Yes, sir. I mean, it depends. You can still carry on. Everybody's watching. There are so many people, but if you're through, then I'm also happy.
She is also tired.
Yeah, I can understand. So it was really a wonderful marathon session, sir. So you've taken it for around 2.5 hours, and I'm telling you, if a candidate is being, interviewed like this, then I think, they will actually learn a lot. Actually, the whole, the India and also abroad, they have learned so much from you for the past 2 days. I really appreciate your endeavor and effort for teaching all the postgraduates out there. Would you like to just end this by telling what books to read and how to go about the exam, attitude of a student? Because this Dr. Samira, I think, has been trained by you very well. Her attitude is very good. Her voice is very good. Her positioning, her stature, everything is perfect. Do you want to advise because next 2 months, the postgraduates are going to take up the exam. Kindly tell a few words how they have to prepare, what books they have to read for ear, nose, throat, and also how they have to be prepared for a Viva exam, please.
Okay, Janki, thank you. Number one, you have only one book. You have one book to read, and if you can read the book, that's more than enough. Scott Brown.
Which edition, sir? Which edition do you recommend?
The one which is previous to this, because the new edition is much more complicated than this 7th edition. That is much better than this. Even that edition also slightly they try to complicate it and give more information than required. When you read the Scott Brown, you need to pick up points from that, not what he has written. You probably need to write your own notes and do this thing. But basically, preparing for the theory, you need to read the books only. There is no other good. There is no other good.
For year, do you suggest any other book, sir? For year reading year, Shambo or
Shambo is a good book. Victor Goodhill is a good book.
What's sir, Victor?
Victor Goodhill is a good book.
Victor Butila.
Victor Goodhill. He's a good book on year.
Okay.
Not many people read that book, but at least it gives a comprehensive message, not the options.
Okay.
So, and the one book, let them be confined to Scott Brown. That's enough. That one book is enough for a thing. Then prepare for the Viva, prepare for the clinical cases. Don't let your juniors tell you the diagnosis. That's the most important thing I'll tell you. And the findings. Don't go to an exam with the bias. Go to the exam without any bias. You examine. The examiner is not going to eat you. The examiner is only going to test only 4 things that I have told you in the beginning. A good history taking, and how you examine do a clinical examination. And then third thing is your capacity to come to a diagnosis using the findings and the history. And then plan an algorithm how you are going to manage this case. That particular case. Don't start saying, if that is this, I am going to do that. That's not what is asked.
Okay.
If the examiner is finished with these questions, he'll start asking you, giving you the scenarios. If it is this, what are you going to do? That is only to test your knowledge further. That means he has already tested you, and the basic knowledge is already being tested. So, and the short cases, don't take too much of a time for examination, only take comparatively less time, and then present confidently. Don't be timid. That's most important thing happens all the time is you sit there, the student starts fumbling and all sorts of things happen there. That's one thing which you need to come out of that. That only way to do that is you keep coming out of the colleges and start presenting cases or start presenting papers in conferences or whatever. That gives you the confidence levels. It has to boost up your confidence level.
Very nice point. Very nice point. So you advise the postgraduates to come out and present in all the conferences so that they'll have a good, during the exam they'll be better.
And most important thing, I want all these postgraduates to ask their professors questions. Most of the time they are all scared to go to the professor and ask a question.
Okay.
Unless you come out of that habit, start asking questions.
Okay.
You can dare to ask the stupid questions here only. Once you go out and tomorrow morning and as a consultant, you can't ask the same stupid question.
Okay. Okay.
So start asking questions to your process.
Okay.
And most of the time, unfortunately, that happens even with my own postgraduates also, they don't ask any questions. They're scared to ask a question. That is another important thing you need to come out of that. And the Viva and all the other things are only testing your knowledge and skills. Now we are also trying to test your skills by asking you to do a presentation and giving a topic presentation also are being done in some of the universities. So you have to be prepared for those things also. Basically, all the Viva or whatever it is a starting point for you. They can take a random X-ray and start from there, and you can go for anywhere from that particular area. So, your preparation of these, your long case, short case is the one tomorrow what you are going to do in your clinic. 15 minutes time, you are given the appointment. You need to have your important diagnostic points and come to a diagnosis and ask for investigations. The long case is the one where you are admitted the patient tomorrow morning and you are planning to operate on him, and what is the workup you are going to do. Oh, we have taken it from the British. It has been taken with a logic. And the Viva and all the whatever stuff is there in the afternoon is all mainly because of you need a point to discuss, start a point of discussion. And the discussion continues. Don't be scared of the 4 examiners sitting on the opposite side. That's all. That's more important. Don't be scared of them. They can only one thing can happen. They can't eat you.
Okay. Okay. Yeah.
Right?
Yes, sir.
And Janki, thank you very much for this opportunity to interact with so many people.
We actually thank you, sir.
My whole gang is here. They all enjoyed the.
Can we see all the others, please? Because the cameraman has focused only 2 of you. Can we see all the others? Because this is going to be the last session with you. Can we have a look at all the others, please? Can the cameraman please zoom?
Yeah, he's doing it.
Oh, wow. Okay. So can you introduce yourself, my dear friends? We usually do that in all the Olympic grand rounds. Now zoom the person because it's from far away. Yeah. Yeah.
Hello, sir. I'm Dr. Jay Krishna, Assistant Professor.
Yeah, perfect. So, madam?
Good evening, sir. I'm Dr. Chandana, postgraduate, sir. First year post. Good evening, sir. I'm Dr. Harika, second year postgraduate.
Good evening, sir. I'm Dr. Lavanya, second year postgraduate.
Hello, sir. I'm Dr. Satish Naik, working as senior resident.
Okay. So it was a very nice, brilliant time with Dr. Samira. I think you should give a gold medal for her. She answered all the questions which were put on to her. And we really thank Alembic. Alembic has done a great work by actually conducting these grand rounds. This is maybe the 10th of its kind being done. So I just want to have a small announcement with your kind permission, Dr. PSN Murthy sir. The next grand rounds will be with Dr. Ravi Nair, and it is on 19th and 20th of February. And he is the ex-HOD of St. John's Medical College and currently the Dean Center of Academic Research, HCG Hospital, Bangalore. So he will be coming to us on 19th and 20th February. Stay tuned. And if you have any queries, please put it forward. I think you can put it forward on the Facebook or on the YouTube. I can get it clarified with Dr. PSN Murthy sir. I am sure be ready to help all the postgraduates out there. Thank you very much, sir, and good night. And sorry for delaying you so long.
It's really a pleasure, Janki.
Thank
It's
you.
a real pleasure to teach the postgraduates. Thank you very much. Actually, I should thank you for giving the opportunity to me.
The other way.